And so for your patient, let's think of a couple different scenarios. So for the patient who has their tours, and let's say it's the small percentage where you don't find it, or I guess, can we unpack a little bit of how pathology is looking at the tonsils and the lingual tonsils? Is that they're doing some frozens at the time of surgery, but then they're also going to do some permanent sections too, right?
They will. So we are very fortunate to have dedicated head neck pathology faculty for every single one of our frozen sections. So that's the first thing, is that this whole process requires a team from not only the oncologists, but even within the OR, and they are instrumental. And I never really understood how important pathology was until I was an attending. And so I realized that we had just developed a system, and working with them is how we came across this. So we bread-loaf the tonsils, and we pick a few spots.
So are you doing that specific? Like, are you doing that yourself, or the pathologists are doing it?
The pathologists are doing that.
Okay. So you send the whole thing.
I send the whole thing. We label it based on anatomical location so that we know, where the tonsil and how it was sitting within the fossa. I usually sit there and watch them do it, and we do it and look under the microscope while they're looking. And so again, they'll take maybe 3 or 4 slices, areas that they think grossly might have or be housing the cancer, and then we'll look. So it's a long process. It extends the day dramatically. We can't move to the lingual tonsil until we've got an answer on the tonsil. And so once we take out the lingual tonsil, typically we'll just check the edges. So then we'll just do what we call shave margins, look at the edge to make sure that we haven't cut across cancer. And if all that's clear, we typically don't always bread loaf the remaining tissue, and we just wait for the permanent pathology. Because if it's a 2 or 3 millimeter cancer, which I have seen, when you run a frozen section, you are at risk of losing that tissue when you're doing the frozen section. It's a fine balance.
Yeah, it's tough. Imagining such a tiny primary and not having a lot of, visual or tactile feedback in the specimen, or when you're, looking in the surgical field to know, okay, I think I've got everything. I think it's that unique situation where looking at it super close under the microscope like that is a really important part of the success of everything.